Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical, free 2-week sessions again. So tonight we are going to finish cardiology, right? We started cardiology session 1 last few days ago, and I think we have finished few of the important cluster. Most importantly, we have done a syncope cluster. And you now also understand how our cluster-wise approach works. You should also understand that using a same format, how much cases you can do, right? So we finished with syncope cluster. We have done some of the cases related to that cluster, and we did some recurrent fall case as well, which is very important for your exam. Sometimes we have noticed that with recurrent fall, few questions also come in exam, like I was discussing about your differential diagnosis and everything, but we noticed that sometimes, apart from diabetes complications, we have seen that sometimes they give you a patient where you don't get any kind of problem, but when you get the physical examination finding, on that finding, sometimes you get ECG showing sinus bradycardia. And sometimes even a sinus bradycardia can be a cause of fall in a very elderly patient. Okay, so sometimes what can happen that with sinus bradycardia, patient can have some other risk factor. So they always give multiple risk factor causing recurrent fall in an elderly patient. So try to find out each and everything. Don't just think that, well, I have got one risk factor and that's it. Most of the time we have seen in recurrent fall, there are multiple risk factor and they actually look for all of those risk factor that you are saying or not. Sometimes we have seen that it is given as polypharmacy-related postural hypertension causing recurrent fall. So that's also a very important exam case. So we'll be doing some role plays on these questions later on. So you'll see how the exam questions can appear. So let's move on to our new cluster today. Everyone got an understanding about the syncope cluster? Any questions so far? Perfect. Let's start with palpitation or nervousness cluster. So palpitation cluster is also important, and palpitation cluster will also cover anyone coming to you with nervousness. So both of them are actually same cluster. So just like always, what are the differential diagnoses of a patient presenting to you with palpitation? So patient will not come to you saying that, doc, I'm having palpitation. So they will come to you that I feel my heart beating, or I'm having racing of my heart, or they can say my heart is jumping. So a lot of things they can say to you, but the main thing is it is palpitation that they are trying to say. So for palpitation, it could be any of these differential diagnoses. It could be CVS related, so ischemic heart disease, myocardial infarction, could be high blood pressure, arrhythmia, valvular heart disease. In terms of CNS, it could be a stroke or transient ischemic attack. It can be epilepsy, infection, or trauma. So same, in CNS, always think that trauma, tumor, infection is stroke, epilepsy. Then come to the endocrine related causes, very important, hyperthyroidism, hypoglycemia, and pheochromocytoma. Anemia can be a cause of palpitation, but it usually gives a chronic palpitation. Same, anxiety disorder, panic disorder, or stress can cause it. Sometimes middle-aged women coming to you with feeling nervousness, palpitation, night sweats, hot flushes, then you'll be thinking about a perimenopausal stage. So for middle-aged female, menopause or perimenopause is a very important DD for palpitation or nervousness. Then what else can cause palpitation? Sometimes even drinking excessive tea, caffeine, even recreational drugs can cause it. And there are some medications which can increase the heart rate also, especially asthma patient taking a lot of salbutamol or Ventolin can end up having a lot of palpitation related problem. Okay. So these are the main differential diagnosis of palpitation. So you have to remember CVS, CNS, endocrine, then anemia, anxiety related, menopause, excess tea, coffee, recreational drugs, and then medication induced. All right. So that will be the differential diagnosis. Now for exam purpose, the most important is arrhythmia. Lots of arrhythmia-related cases come in exam, such as atrial fibrillation, SVT, atrial flutter. Okay, and then sometimes we have seen hyperthyroidism can come, hypoglycemia can come as nervousness, and some obviously anxiety disorder is a part of psychiatry case. Menopause, very important. It comes with nervousness or palpitation. Sometimes even excessive coffee intake. That also I've seen one time in the exam. So excess coffee intake can cause palpitation and medication induced. Anytime in exam, you should always keep an eye on what medication patient is taking, because they love to give medication induced side effect in the cases. Okay. So moving on to the history format. So in case of palpitation, patient mainly presents with an acute presentation. So they will come to you that patient was running on the street and suddenly started to feel palpitation, and then they come to the emergency department. So it's acute, so you have to make sure patient is hemodynamically stable. We had a discussion last class that how to start these cases. If any of you missed that class, make sure you do that, because we have discussed about the approach. So we will not discuss now what is the difference between face-to-face and online approach, because we have a discussion already on that. But as part of an online exam scenario, we will start in this way in here. So hi Jenny, this is Dr. Arshan. I'm one of the doctor in this emergency department. I understand from the notes that you have been feeling racing of your heart for the last 2 hours. I'm so sorry to hear that, but now that you are here, I'll be taking care of you, and I'm hoping that I should know what's causing these palpitations that you're having. Now, before I ask you any questions, I need to ensure that you are hemodynamically stable. So I will check your blood pressure, pulse, respiratory rate, and just to make sure that you are good to start with our questionnaires. Is that okay with you? Yes, doctor. Well, so Jenny, would you please tell me a little bit more about this racing of the heart that you are feeling today? Now, remember I said that for online, there is no way we can check the vitals because examiner doesn't give that to us. So we will just pretend that we are checking it as part of a normal case. We would always do that. So we would do that first, and then we will just move on to our next task, which means that we will ask the patient an open-ended question. So Jenny, can you please tell me a little bit more about this racing of the heart that you are feeling? Patient will give you some of the informations, but you need to make sure you get this information. So you need to know, when did it start? How did it start? That means what exactly were you doing at that time? Did it start suddenly or gradually? And is it for the first time? Many times patient will say, no, doctor, it's not the first time. So in that case, you have to ask the detail of the previous episode. That means, can you tell me a little bit more about the previous episodes? How many episodes so far? What brings these palpitations? And what makes it stop? And when it comes, how long does it last? Do you do anything which can make it stop? Have you seen any other doctor for this before? Okay, so ask a little bit about the previous episodes. And then you can ask, anything makes it better, anything makes it worse? Is it continuous or on and off? And how long each of this episode lasts? Okay, so this is your palpitation history of presenting complaint. After that, you will move on to the associated symptom. So along with palpitation, what else we are looking for? Anything related to heart. So you are asking about, during these episodes, do you feel dizzy or lightheaded? Very, very important is this question, that palpitation most of the time will be associated with feeling dizzy or lightheaded. Okay, so ask this question and finish all the CVS and CNS differential diagnosis questions in here. So for CVS, you have any chest pain, any difficulty breathing, any nausea, vomiting, excessive sweating. So that's for myocardial infarction. And then for CNS, you're asking about any headache, any blurry vision, any difficulty with your speech, any weakness, or any loss of consciousness. So what you have just done is that you have asked palpitation detailed question, then associated dizziness or lightheadedness. You have asked the differential diagnosis in terms of CVS and CNS, and then move on to some other. So next is if you come back, after CVS, CNS, you have endocrine. So ask endocrine questions, hyperthyroidism. So ask any recent change in your weather preference. So patient who has hyperthyroidism, they feel hot and sweaty all the time, and they will usually prefer cold weather. So you ask the patient that any recent change in your weather preference. If patient doesn't understand it, you can directly ask that do you feel excessively hot and sweaty all the time? Any change in your bowel habit, any change in your body weight. So hyperthyroid patient, they will have diarrhea, they will have loss of weight. So they say that I'm eating a lot, so I have an increased appetite, but still I am losing body weight. So that's a classic picture for hyperthyroidism. Then move on to pheochromocytoma. Pheochromocytoma, it's a tumor of the adrenal medulla, and it's most of the time it's a benign tumor, but it presents with a paroxysmal attack of headache, flushed face, sweating, and hypertension. So you can ask the patient any episodic headache, flushing of the face, or any excessive sweating. For hypoglycemia, did you skip your meal today? Because many times what patient does, that patient was supposed to have a good breakfast before going for exercise, but without doing that, patient just went out and did a very heavy exertional activity, which ended up causing a hypoglycemia. So you can ask the patient, by any chance, did you skip your meal today? So you have done your CVS, CNS, and endocrine. Now move on to anemia. So you can ask, do you feel tired and fatigued these days? If they say yes, then we will move on to more questionnaires related to anemia. Otherwise, just one question is enough. Sometimes recent infection or ongoing infection can cause palpitation. So you can ask any fever, any cough, runny nose, any flu-like illness. Electrolyte imbalance can be a cause, so any vomiting or diarrhea. And then ask about all other questions. So SADMA, so do you smoke or drink alcohol, any recreational drugs? Do you drink a lot of tea or coffee? If yes, then ask how many cups of tea or coffee do you drink in a day? Ideally, 2 cups of coffee or tea is fine, but patients who is drinking 6 to 8 cups of coffee in a day, they can obviously get a lot of palpitation. So find this out also. Any other past medical history, such as diabetes, high blood pressure, or any heart condition, any family history of heart disease or sudden death due to heart-related cause. And obviously, even after this, you have to ask about social history. So, because many times anxiety disorder, stress, panic attack can be a cause of palpitation. So just ask the patient that I'm going to ask you some personal and private question regarding your home and work situation. Please be aware that these are confidential between you and me. So do you have any stress at home or at your work? Do you worry a lot about most of the small trivial things? Do you know why we ask this question? Like, do you worry a lot about most of the trivial things? Yes, very good, Dr. Ajela. So we are asking about generalized anxiety disorder because that can be a cause of palpitation. So ask about these anxiety related questions because many times that might be the case that they have given in your exam. So give a confidentiality statement and then just ask, so who do you live with at home? Is there any stress at your home? Do you do any work? Is there any stress at your work? Any financial issues? And then ask about, do you worry a lot about most of the small trivial things? If it is a female patient, your one of the differential diagnoses should be menopause, especially middle-aged. So ask about that. When was your last last menstrual period. If it falls under menopausal age group, which is between 45 to 55, then ask some of the menopausal symptoms. So are you getting any hot flashes these days? Any night sweats? Do you think you're always on the edge? You feel irritable and anxious all the time? So ask some of the menopausal symptoms in that case. Okay, so basically this will be your history here. After finishing the history, just thank the patient, say that thank you, Jenny, for all the information you have given, and then you move to the next task. So if we go back to our history format, so you will start with your introduction, approach, reassurance, make sure patient is vitally stable, ask the palpitation question, followed by all the differential diagnosis, CVS, CNS, endocrine, and then anemia, infection, electrolyte imbalance. Finish with SADMA. So SADMA is basically it's smoking, alcohol, and drugs. We don't need to ask like others like allergies, medications, and those things. For SADMA, we just ask, do you smoke or drink alcohol, any other recreational drugs? That's SADMA. And then tea, coffee, finish with past medical history and family history and social history. All right. So that will be your history in this case. And you can use this history for any palpitation cluster. Now, physical examination from examiner. We discussed about the physical examination already in our last session, so we don't need to do that again. The physical examination will be exactly same like before. Nothing is different. We will start the case. So supraventricular tachycardia. This is the case that sometimes come in your exam. So you're a junior HMO in emergency department. A man came in with thumping or racing of the heart and also giddiness, which started today. Your task is to take history from the patient. Now in online exam, your second task most of the time will be physical examination will be given on the card. Ask investigation from examiner and then discuss the investigation with the examiner. Many times they give you a ECG and they ask you to interpret the ECG to the examiner and then explain the diagnosis and differential to the patient. So this is the usual case in these cases. Sometimes management can also come in the exam. Not very common, but you should know about it. So positive points in this case is that patient having palpitation and lightheadedness for 2 hours. Okay, and also feeling short of breath. Previously, he had 3 episodes which started suddenly, lasted 2 hours, and then stopped all of a sudden. Patient takes 6 to 8 cups of coffee in a day. So that's also one of the other positive finding. No smoking or alcohol, no family history of heart disease. Patient is also quite an anxious personality, and there is positive stress in the life. So you can see a lot of findings in a patient. That's what I'm trying to say for a while, that in exam, many times why candidates fail is that because they just focus on just a one particular thing. But many times they give more than one things which they're looking for. If you just get 1 point, that's not enough to pass the attestation. All right. So look for everything. And that's why this format helps a lot, because within the format, everything comes. And if you don't need to like think that what I have missed, if you finish the format, then most of the things that can be given to you, it will be covered anyway. So that's the positive point in this patient. So you will just ask the same history as we have done so far. In the physical examination, there will be nothing abnormal in this case. Your third task is ask investigation from examiner and then interpret it. So that will be like you will say that, dear examiner, I would like to do a 12 lead ECG for my patient, please. So then the 12 lead ECG will be given on the screen like this, and you have to interpret this to the examiner. So this is a little bit complicated because within that short period of time, you have to find out what's given on the ECG and you have to interpret it. So if you see here, remember I told you your stem, the information given by the patient, that will give you some idea that what you should look for in the ECG. This patient came to you with palpitation. So what is the most important thing you will look for? You look at the long lead, which is lead 2 in here. And in long lead, you will be looking for anything which can cause palpitation. So you know that most common questions are SVT, AF, such as atrial fibrillation, atrial flutter. Those are commonly asked questions. So you'll be looking for those first, right? So if you see here, first of all, look at here. So how to find out the rate in an ECG? Now, do we need to exactly calculate the heart rate in ECG? No. You just need to give an approximate value. That's more than enough. So if you see here, this is the RR interval, right? So if this is the P wave, right? Now this is R, this is R, this is P wave, this is QRS T. Okay. Now this is T, this is RR interval. And this RR interval is important to calculate the heart rate. And most importantly, first have a look that if this RR interval is regular. If RR interval is regular, it means that the rhythm is regular. So first thing we look at is heart rate and rhythm. So if we see in here in this patient, so you find out how much large square is there. Okay. So you find out how much large square in between one RR interval. So if we see here, let's say that it is actually more than 1, right? So if we put here 300 divided by 1. So it's usually like this. So you say that heart rate equal to, if the rhythm is regular, then heart rate is equal to 300 divided by number of large square in between this RR interval. Okay. So in between these two RR interval, how much large square is there? You will just divide it in here. So if there is only one large square, then heart rate will be 300. If there is two large square, heart rate will be 150. In that same way, if 3 large square, heart rate will be 100. If 4 large square, heart rate will be 75. So it's very easy if you just memorize this number. You don't need to even calculate anything in the exam. Right? Now, in this case, you see that it's a little bit, like it's not just one large square, a little bit more. So you can say that if you say not 300, maybe just say 250 or 280, then you will get the right answer. Okay? So just an approximate value we'll do in the exam. All right. So is this clear for everyone how to get the heart rate? Yeah, very good. So let's just erase this part. And if it is irregular, then you don't need to calculate the heart rate because it is complicated, and you need to actually measure how much large square is there in 30, how much RR interval is there in 30 large square, so which is not needed for the exam. And it's what we normally do if it is a irregular heart rate. We just say that heart rate is increased, or heart rate is increased, rhythm irregular. So that's all that we need to say. Okay, but if it is a regular rhythm, such as in SVT or atrial flutter, what you normally need to do is just find out how much larger square is there in between two RR interval, and then just find it out like this. It's easier in that way. Now, after we have found the rate and rhythm, then we find out how about the P wave. So you see in here, let's just start with one of these. So you can see that the rhythm is regular in this patient, but all we can see that there is no P wave. So after each of these QRS complex, there is a T wave. So this is the T wave, but there is no P wave. Okay, so lack of P wave, rhythm regular, heart rate increased, and you also get a narrow QRS complex. Ideally, the QRS complex is between 1 to 2 small square. But in patient with SVT, the QRS complex even become less than 1 small square. It's a very narrow. You can see how narrow it is, but normally it should be between like this. Okay, so narrow QRS complex is one of the finding of SVT. So if we come here, this is what you will get. You can see here, this is QRS complex, which is narrow, and then there is T wave, but there is no P wave. Okay, the rhythm is regular because every RR interval is equally spaced. So that's what you will get in a SVT patient. So how we explain ECG to the examiner? Even before that, you will first see, if you have to first be sure in the exam that this is SVT, and then quickly look at other part of the ECG for any other changes. And even if you just find out SVT in the exam in that short time, they will be happy with you. Okay, so let's come to the discussion of explain ECG to the examiner. So when you will explain an ECG to the examiner, you will say, "Dear examiner, I would like to describe the 12-lead ECG of my patient, Mr. John, who is a 25-year-old gentleman, came with sudden palpitation and giddiness. The ECG shows heart rate of 150 beat per minute. In this case, it was actually about 250 beat per minute. So heart rate 250 beat per minute, regular in rhythm, absence of P wave." So we will always follow a format when we discuss the ECG. So you will start with rate and rhythm. After rate and rhythm, you will do P followed by QRS and then T. So absence of P wave, narrow QRS complex, and no STOF changes. So this is the STOF, right? So ST is also normal. So no STOF changes. T wave, so this is the T wave, which is normal in size and shape. And then lastly, we talk about the QT interval. So this is the Q and T. So QT interval is also normal. Okay, so this is how we interpret an ECG and explain that to an examiner. So always a format should be there. It should not be an haphazard explanation. So first rate, then rhythm, then talk about P wave, QRS complex, ST wave, T wave, and then QT interval. Okay. After you have explained the ECG to the examiner, your next task is to explain the diagnosis to the patient. So you'll say that, "John, thank you so much for waiting. From history, physical examination, and also the ECG that we have done, it seems like that you are having a condition called supraventricular tachycardia. Do you know what it is?" "No, doctor." "Well, let me discuss in detail. So remember when the nurse put those leads on your chest? That was the electrical record, which is what we call as electrocardiogram or ECG. The lines that you can see on this paper is a result of the electrical impulse that's conducted in your heart. So in our heart, there are electrical impulses that originate from the top part of the heart, and then it goes all over the heart to pump the blood to our body. So drawing the picture is very easy for a patient to understand, but for online, we can't do it. But make it as simple as possible. Just say that in our heart, there are electrical impulses which originate from the top part of our heart, and then it goes all over the heart to pump the blood to our body. In your case, there is some abnormality in this electrical impulse, causing your heart to beat faster than normal. And that's the reason you are having racing of your heart. And because your heart is not getting enough time to fill in, your brain is not also getting enough blood supply, which is causing the lightheadedness that you are having. And that is why we call it supraventricular tachycardia, because this abnormal impulse is originating from the upper layer of your heart. Are you with me so far, John? Are you understanding me? So always make sure after explaining such a difficult thing, if patient is understanding you. Remember one thing, patient doesn't care about ST wave and all of those things. Patient doesn't care about the reading of the ECG. If you start explaining this is P wave, this is QRS complex and all of those things, patient will not understand anything. Even for junior doctors, it is very hard to even understand this ECG by themselves, right? Many of you struggle with ECG. So how a patient will understand ECG just within a second? So please do not try to teach them the ECG. Just keep it simple as you can, and making sure that patient understand why they are feeling this palpitation and why they are feeling lightheadedness. That's all they care. So then you can say there could be many reasons behind it. So sometimes even supraventricular tachycardia, it can happen in a normal healthy person without any underlying heart condition. Sometimes it can be due to a structural heart disease, valvular abnormalities. Sometimes it could be medication-induced recreational drug intake, thyroid problem, infection, salt imbalance, excess tea, coffee intake, etc. And in here, you can say that in your case, I feel that the excess tea, excess coffee that you are having, that might be one of the reasons that you are getting this. But we can't be totally sure. It could be something in the heart as well. So we will need to do further investigations to find that out. Apart from supraventricular tachycardia, this palpitation can be due to any other rhythm disturbance in your heart, but those are unlikely given the ECG finding that we have got. Then you can also give other differential diagnoses, like it could be due to any nervous system problem, such as a stroke, mini stroke, but in your case, you don't have any weakness in your body, so it is unlikely. It could be due to other conditions such as epilepsy or seizure, but you did not have any jerking movement in your body, so it is unlikely. So just give some of the DD and say why it is unlikely. Okay. Now, if management comes in SVT, which I haven't seen a lot in the exam, just get a basic idea that how to manage SVT in a patient. But in exam, most of the time they just ask the diagnosis, differential diagnosis. So in terms of management of SVT, it depends on a lot of factors if the patient is vitally stable or not. If the patient is not vitally stable, that patient will not be given to you in the exam. And the treatment of a vitally unstable SVT is cardioversion. So that's usually not the exam case. If the patient is vitally stable and still SVT is ongoing, patient's heart rate is still high, in that case, obviously this needs to be managed in the hospital, in the emergency department. But what you can do is that you can start with a vagal maneuver or Valsalva maneuver. So you'll do vagal nerve stimulation. So this vagal nerve stimulation can be done with a lot of things. One, that you can do Valsalva maneuver. You can do carotid sinus massage. You can ask the patient to immerse their face in a cold running water. So any of this will stimulate the vagal nerve, which can reduce the heart rate. Okay. So you can say what is, like, they don't ask you to explain carotid sinus massage or vagal maneuver. Carotid sinus massage is not ideal in an elderly patient because there is a risk that if there is a carotid artery stenosis and if you do the massage, you can cause a dislodgement of a clot, and that clot can end up causing a stroke in a patient. So ideally, carotid sinus massage is not important for middle-aged or elderly patient. Young patient, we can do it. but the best would be a Valsalva maneuver. You ask the patient to take a deep breath through their mouth and ask the patient to close their nose and then breathe out through their ears. Okay, so you ask the patient to close their nose, take a breath in through their mouth, and then breathe out through their ears. So that's Valsalva maneuver. This is the first thing the patient will give a try. If that doesn't help, the next part will be medication, which is IV adenosine. IV adenosine can be tried on multiple occasions. So if first IV adenosine doesn't work, then again you can repeat it. If IV adenosine is not available, then calcium channel blocker like verapamil can be tried as well. Okay. Now, even after that, if still patient is not getting better, then sometimes they might need to go for cardioversion. So that's the treatment step by step for SVT, which is not needed for you, but I would say we never know what comes in exam. Understanding and knowing this will just make you confident for exam. Okay, so that's supraventricular tachycardia. Any question? Good question, Dr. Javeria. Can we get time to understand that ECG, like 1 or 2 minutes, or we have to just start speaking? Now, not 1 or 2 minutes. That's 1 or 2 minutes is a long time. You will get some time, but ideally maybe 30 seconds. That's highest you should use. So very quickly you have to do all of those. And it's better to wait and be sure before speaking something wrong in the exam. Because once you have given the diagnosis, that's it. So if you can take the history pretty quickly, and if you give some time for understanding the ECG, that's not a fault. There is no specific timer there that you have to do the ECG within 30 seconds, but it's better to do it as early as possible because you will be running out of time otherwise. Common ECG. Okay, so they give common ECG in the exam. They don't go into the complex ECG in the exam. You are a junior doctor in this exam, so all the common ECG is needed. Next question, atrial fibrillation. So a middle-aged lady coming to you in the emergency department with sudden onset palpitation. History, physical exam, same thing. In online exam, do we need to explain to examiner if that's the task? Sometimes examiner is not talking to you, but the task is that you have to explain to the examiner. So examiner is actually listening to you, but they are not replying you back. So yes, in online exam, sometimes we get tasks like this that you have to explain to the examiner, but don't think examiner will talk to you. You'll just pretend you're talking to the examiner and they will be listening to you. Okay? Now, the next one is atrial fibrillation. So you can see the history is same. So for atrial fibrillation, patient will come to you with palpitation as well. History same, physical examination same. And when you ask for the investigation, they give you the ECG and you have to read the ECG. So if you look at the ECG, that's lead 2, what you see here is the irregular rhythm, right? You can see that. So all the RR interval are irregularly placed. After that, even with getting an irregular heart rate like this, you know that this might be atrial fibrillation. So then you look for any P wave. So you can see that sometimes it can be quite difficult to get that fibrillatory wave. But if you look in here, you can see some of these fibrillatory wave. Okay, so these are all fibrillatory wave. The one that you see here, these are T wave, not P wave. So what happens in atrial fibrillation? Heart rate will be elevated, rhythm will be irregular. The P wave will be replaced by some fibrillatory wave like this. Okay, so you can't see a single P wave, but it will be like this. If it becomes like sawtooth appearance like that, that's atrial flutter. Okay, so for atrial fibrillation, that's the main finding. if you come here, you can see that we have explained the ECG in the same way. So in here, you don't need to say what is the heart rate. You can say that heart rate is increased, irregular rhythm, absence of P wave, which is replaced by fibrillatory F wave. In this case, you can also get a narrow QRS complex. ST wave will be normal, T wave will be normal, and QT interval normal as well. All right. So that's what you get in the ECG for atrial fibrillation. And quickly have a look on the chest lead and everything, but all that they care is lead 2. If you can explain it properly in that short time, they are happy. Okay. Everyone clear with the atrial fibrillation ECG? So in atrial fibrillation, the main thing you look is the irregular rhythm, and you will find out that there is no one specific P wave. The P wave will be replaced by some fibrillatory wave like this. Okay, so once you have explained the ECG to the examiner, the next task will be explain the diagnosis to the patient. And sometimes they also give you another task. So the task is like this: explain the cause and implication or complication of the condition. So they ask you what is the cause of atrial fibrillation and what is the complication of it. And sometimes even management comes in exam. So if you come here, so atrial fibrillation explanation is exactly same like as SVT. How so? So if you come to SVT explanation, so you'll say the same thing. You'll say that from history, physical examination, and the ECG, most likely you are having a condition called atrial fibrillation. And what is atrial fibrillation? Same. So it also the heart beats in a chaotic rhythm, right? And the abnormal impulse also originate from the top of the heart. So you will say that in atrial fibrillation, so you will say most likely it is atrial fibrillation, and in the ECG, or you can say that remember when the nurse put those leads on your chest, they have recorded the electrical activity in your heart, which is what we call as ECG or electrocardiogram. The lines that we see on an ECG is result of electrical impulse that conduct in our heart. So in your case, the electrical impulse, so in a normal heart, electrical impulse originate from the top part of the heart, and then it goes all over the heart to pump the blood to our body. In your case, there is some abnormality in the electrical impulses, causing your heart to beat faster than normal and also chaotically. And those abnormal impulses are originating from the top layer of your heart. Because your heart is beating chaotically and irregularly, you are getting this racing of your heart. And because of that, your heart is not getting enough time to fill in. So your brain is not getting enough blood. That's why you are getting the lightheadedness. So it is exactly the same explanation, but only thing that we add is your heart is beating chaotically. That's it. Everything is same. Okay. So your explanation will be like this, and then you can say that there might be a lot of reasons of having atrial fibrillation. Sometimes it can be totally unknown cause. Sometimes it could be due to high blood pressure, which could be a positive finding in the patient. So if it is positive, you can say in your case, this is the most likely reason. It could be also due to underlying heart artery problems such as coronary artery disease, heart attack, abnormal heart valves. The valves are door-like structure which divide each chamber in our heart. It could be heart defects that we are born with, any overactive thyroid gland, which is a butterfly-shaped gland in our neck. It could be due to some medication, excess coffee, alcohol, or smoking. Sometimes even it could be due to lung disease, previous heart surgery, even viral infection or stress. Okay, so these are all the causes of AF. And then say your next task is complication of AF. So this atrial fibrillation, the chaotic rhythm may cause the blood to pool in your heart upper chamber, and it can form clots. If a blood clot forms, sometimes it can dislodge from your heart and can travel to your brain, which can block the brain blood flow, causing a condition called stroke. Sometimes, if atrial fibrillation is not well controlled, it can weaken your heart and lead to heart failure, a condition in which your heart cannot pump enough blood to meet your body's needs. Anytime you say something like scary like this, always end with some reassurance. Say that please don't get scared about these complications. It is not like that you are going to get it. Now that you are here and we know that you have got such condition, we can treat you with good medication and it can be managed quite effectively. So always make sure if you say something is scary to a patient in the exam, say something nice and reassuring at the end. That will make up. Otherwise, patient will start to get the palpitation and heart will start to beat more faster, which you don't want, right? So that's important. Now, management of AF, sometimes it can come. It's not always, but we should have an idea about it. So for AF management, again, we need to know if the patient is vitally stable or unstable. Unstable patient, cardioversion is the choice. For stable patient, the management is divided into multiple steps. First of all, we do rate control. So if the heart rate is elevated, then you will go for rate control medication. So you can start with any of the beta blocker. So atenolol, metoprolol, carvedilol, any of the cardioprotective beta blocker, that will be the first choice. If beta blocker is not available, then rate limiting calcium channel blocker, such as verapamil or diltiazem. Okay, so that's your rate controller drugs. If rate control is not effective, then you can try rhythm control drugs. The rhythm control drugs are antiarrhythmic medication such as plecainide, sotalol, or amiodarone. So these are the antiarrhythmic drugs that can be tried. And even after rate and rhythm still there is ongoing problem, then sometimes we need to go for cardioversion. So this is the management for atrial fibrillation as part of AF management. So rate controller, rhythm controller, and cardioversion at the end if needed. Apart from that, AF management is never finished until you talk about the prophylaxis to prevent a stroke in this patient. So because this patient is high risk to have a stroke or TIA, you have to find out if this patient fulfills the criteria to get a prophylactic medication for that. And how we do this? So we use a scoring system which is called Chatz-Vosk score. This Chatz-Vosk score is going to help you to find out if this patient is a high risk for a stroke or not. Now, I'm not going to discuss detail about Chatz-Vosk score. You can go through the Google about this Chatz-Vosk. And the main thing is that if the score is 0, then there is no need of any prophylaxis. But if the score is more than 1, more than equal to 1, now there are a few other things for men and women. For men, more than 1, you have to start the anticoagulants. For women, you can go for up to 2. Okay, so men above 1, anticoagulants. Women above 2, anticoagulants. Now, what kind of anticoagulants we use for atrial fibrillation, guys? No longer warfarin. This is wrong. So we no longer use warfarin for AF patient unless it is really needed. So nowadays the guideline has changed. So guideline is, let me just draw for you. So the guideline is something like this. So if AF patient needs anticoagulants, in that case, you will first find out, is this patient having any prosthetic heart valve or any valvular problem? If it is a valvular heart disease patient having a AF, that's the only time warfarin is indicated nowadays. Because warfarin needs daily INR checkup, it is very hard for a patient and the side effects profile are also very high. So we try not to give warfarin unless it is really indicated. Non-valvular AF, so this is the greater population, they are going to get newer oral anticoagulants, NOACs or DOACs. Okay, and in newer oral anticoagulants, we have got apixaban, we have got rivaroxaban, we have got dabigatran. So any of these NOACs will be our ideal choice for AF patients for a prophylaxis against a stroke. Okay, so this is the whole management of AF. Also, AF patients, you will be doing some baseline blood tests. So you will be doing all the full blood count. You will check the thyroid function, obviously, in this patient. You will be checking lipid profile, blood sugar level. Those common investigations you will obviously do. You will also do an echocardiogram on the heart, just to be sure there is no structural heart defect and the heart function as well. And after that, obviously, this is the management as well. So management starts with stable or unstable. If it is stable, then rate control, rhythm control, cardioversion. And then you have to find out if this patient is a high-risk patient for developing clot or a stroke. If it is a high-risk patient, you have to start the patient with anticoagulants. Okay, all good? Any questions? All right, now before we move on to our next cluster, let's take a 5-minute break and then we will start with our chest pain cluster. So this is all about palpitation cluster. Not much of any other ECG, it comes from palpitation. So atrial fibrillation, sometimes maybe atrial flutter, and SVT. This is the commonest palpitation related questions. Okay. So let's take a 5-minute break, guys. Then we will start with chest pain. All right, everyone, let's start again. So, very important cluster for cardiology, chest pain cluster. Very important. I can't say how important it is. Every every month you will get a questions from chest pain cluster. Every month. So chest pain is always important, as you can understand. So starting with the differential diagnosis of chest pain, there is a lot of chest pain differential diagnosis. So you have got CVS related cause such as angina, myocardial infarction, pericarditis, aortic dissection, aortic stenosis. And after CVS, you have got respiratory related, which is pneumonia, pulmonary embolism, and pneumothorax. GIT related is also important. We have seen a lot of cases coming from GIT. So gastroesophageal reflux, peptic ulcer disease, musculoskeletal such as costochondritis, rib fracture. Then you have got neurological like prolapsed disc. So if there is a thoracic disc prolapse, that can cause a referred pain to the chest. Herpes zoster, sometimes what happens that herpes zoster rash starts after the pain. So pain starts first and then the rash appears, right? So during that pain phase, when there is no rash, sometimes it could be just a herpes zoster pain. And obviously psychological cause is there, anxiety, panic attack, stress, all can end up causing a chest pain. So these are all the differential diagnoses for anyone presenting to us with an acute chest pain. But most important is always CVS. Now, this is the most important thing, that how to start a case with chest pain. So, first of all, you have to use your own sense that how risky is this patient. For a 30-year-old, we are not very concerned about having a heart attack. But the same case, when it's above 40, we are concerned about a heart attack. So, depending on the age, we always be a little bit cautious. So let's say it's a 45-year-old patient coming to you with a chest pain for the last 2 hours. You will be very concerned about it, right? So how will you start that case? So for online, so first of all, you will, hi John, this is Dr. Arshan. I'm one of the doctor in this emergency department. It's very nice to meet you. I understand from the notes that you are having a chest pain for the last 2 hours. I'm very sorry to know that. John, would you please tell me how severe is your pain in a scale of 1 to 10? So either you can make sure patient is vitally stable and then give the painkiller, or you can give the painkiller first and then make sure patient is vitally stable. Any of these two is fine. Let's say we are preferring to give the painkiller to the patient first. So John, would you tell me how severe is the pain in a scale of 1 to 10? Patient says, doctor, is 9 by 10. What will you say? I'm so sorry, it must be severe for you. So I'm going to arrange some painkiller for you now, but do you have any allergy to any medication? No. Well, that's really good to know. So I'm going to arrange the painkiller for you. Hopefully you will feel comfortable. So this is the first thing will you do. Make sure before giving any medication to a patient, make sure patient is not allergic to that. It's must to ask. Once you have arranged a painkiller for the patient, then you say that, John, before I ask you any more questions, I need to make sure you are vitally stable. So I'm going to check your blood pressure, your pulse, your oxygen saturations. And if that is all good, then we're going to start asking questions. Is that okay with you? Yes, doc. Well, John, would you please tell me a little bit more about the chest pain that you have got? So that's your HOPC, which is chest pain, and you are going to ask him detailed question about it. Few other things before we move on is that many times I have seen candidates, they are confused about this painkiller, how we are going to arrange a painkiller for the patient in online setting. This exam is all about pretending and acting, right? Because these are simulated cases. So as long as you are offering something, as long as you are saying those things, it means you are doing it in the real life. So you don't necessarily have the painkiller in front of you and give it to the patient, and patient needs to take it in front of you. It's not like that. As long as you say that you are going to arrange this for the patient, that's enough. Okay, so don't get confused with that. And we don't need to specify which medication we are giving. We are just saying that we are going to give you a painkiller. Okay, for AMC clinical, very less time we will be using the name of the medication. Now, after that, we ask the patient, can you tell me a little bit more about this chest pain? So patient will give you some information. And after that, you will ask the patient, when did it start? What exactly were you doing at that time? Now, let's just stop here a little bit, because there are a few other things we do in this case as well, depending on the question. You will come across a question just in a moment, that question, they already give you a scenario where you already know this patient having an acute myocardial infarction. Now, as I said in the first discussion, that the age, the question, everything actually is important to know that how risky is this patient to get a heart attack and how you're going to respond to it. So if you think that the age group is within the problematic group, in this situation, after you have made sure patient is vitally stable on all of those, so I would take this patient to the resuscitation room and making sure patient is taken care of. So what I would do in this case, first of all, you will introduce with the patient and you will say that you are going to arrange the painkiller for the patient. And after arranging the painkiller, you will say that, John, because of your age and the duration of the chest pain, I am a little bit concerned about it. So what I'm going to do is that I'm going to take you to the resuscitation cubicle and I will ask my nurse to hook you in an ECG monitor, and they are going to arrange an ECG for us to have a look at your heart. They're going to also insert 2 large bore IV cannula and take some blood for necessary investigations. Okay. Now, sometimes, even if they give you the ECG showing acute myocardial infarction on the stem, along with all this I have said, you can also start the patient with 300 milligram of aspirin as a loading dose. But when we don't know if this patient has got a heart attack or not, we don't need to start aspirin straight away. Okay? So for this case, the format that we are doing, we don't know the ECG yet. So we are just taking the patient to the resuscitation cubicle. We are asking the nurse to hook the patient with the ECG monitor and then organize an ECG to be done straight away. Insert 2 large bore IV cannula and then take some blood for necessary investigation, most importantly, a cardiac enzyme. Okay, so once you have done this initial part, then you are going to start asking questions to the patient. Is this making sense for everyone? And all other, so we will come into that monotherapy for acute myocardial infarction later on, but oxygen is only needed if patient's oxygen saturation, if we find that it is less than 95%, then only. Not everyone needs an oxygen. Okay, so once we have done this part, then we are going to move on to the chest pain question. So we will ask the patient an open-ended question, and we need to find out, when did it start? What exactly were you doing when this started? Did it start suddenly? And is it for the first time? Is it continuous or on and off? Can you exactly point out the site of the pain for me? Does the pain travel anywhere? So that's the radiation question. You can't ask medical jargon, remember? So you can't ask that, does the pain radiate to anywhere? So you have to say, does the pain go anywhere? Does the pain travel anywhere? Can you describe the pain for me? how does it feel like? So if it is feels like tightness, pressured feeling, that's heart attack. If it feels like burning chest pain, that's likely to be a gastroesophageal reflux. If it is a sharp stabbing pain, it could be a pericarditis pain. Okay, if it is a severe, excruciating, like cutting knife-like pain, which radiates to the back, it can be aortic dissection pain. So we need to know the characteristic of the pain. Anything makes it better, anything makes it worse, like breathing, coughing, or doing any exertion. If chest pain gets worse with exertion, that's heart related. If chest pain gets worse with coughing or taking a deep breath in, that's likely to be a pericarditis chest pain. Okay, so this is important to know. And what we are mainly doing in here, we are doing a Socrates pain questionnaires. So in Socrates, we know we need to ask about the site of the pain, onset, so when did it start, character, so how does it feel like, radiation, does the pain go to anywhere, then we need to do associated symptoms, which we will do now, time, so how long you are having the pain or when did it start, anything makes it better, anything makes it worse, and then the severity, which we ask first. So the Socrates question is every pain related cases, we will be asking the same Socrates questions. So just make sure you remember it. Okay. Once you have done the chest pain questionnaires, then you go to the associated question. In the associated questions, so you will say along with the chest pain, do you have any shortness of breath, any racing of the heart, any nausea, vomiting, or excessive sweating? This is basically your myocardial infarction question. So any associated shortness of breath, racing of your heart, nausea, vomiting, or sweating or excessive sweating. So once you have asked those, you will move on some other DD. So you have other DD for CVS, which is pericarditis and aortic stenosis. So you can ask, does the pain get worse when you take a deep breath in or when you give a cough? That will be positive in pericarditis. Does the pain get worse when you lie down? And does it relieve when you lean forward? So pericarditis pain, it is a sharp stabbing pain which gets better with leaning forward. So sometimes even in the exam, the role player try to show it to you by leaning forward. So that's a clue to you. And also it gets worse after lying down or taking a deep breath in or coughing. And many times you will get a recent flu-like illness positive. So any recent flu-like illness. Then for aortic stenosis, remember the triad. So you already have got chest pain. So along with chest pain, we have got shortness of breath and syncope. So ask the patient that any dizziness or sudden blackout. You already asked chest pain and shortness of breath in the previous questions, right? You asked shortness of breath, you asked chest pain questions in here. So that will cover your CVS related DD. Then you move on to respiratory system. So pneumonia, pneumothorax, pulmonary embolism. So for pneumonia, we have 4 questions. So fever, cough, shortness of breath, chest pain. Shortness of breath and chest pain you already asked. So ask any fever, any cough. You can also ask any reason, or you can also ask any flu-like illness. For pneumothorax, any trauma to your chest, any history of any lung condition. For pulmonary embolism, there's a lot to ask from pulmonary embolism, but only 1 or 2 questions you can ask here. So any recent long travel to anywhere, any previous or family history of clot formation in the legs or lungs. So that will cover your respiratory system related questions. Then for GIT, you have reflux and peptic ulcer disease. So ask, does the pain has any relationship with food, any heartburn or any bitter taste in your mouth? You can also ask any pain in your tummy after eating food, which relates to peptic ulcer disease. After that, we move on to musculoskeletal chest pain. So even sometimes you can ask that, did you do any heavy lifting, any unusual exertional activities recently? Because that might be a cause of musculoskeletal chest pain. And for costochondritis, you can ask, is the chest sore to touch? So in costochondritis, the costochondral junction becomes tender. Sometimes even a tender swelling can be found. So when you press the chest, it will be sore to touch. Then for neurological, you can ask any history of back pain issues. That's for prolapsed disc. And also ask herpes zoster, so any rash on your chest. And then you have got anxiety or panic attack. So they give some confidentiality statement and then say that, how are you doing at, like, who do you live with at home? Is there any stress going on at your home or at your work? Are you generally an anxious person? Or do you worry a lot about most of the small things? So anxiety, stress, that can be a cause of psychogenic chest pain as well. And lastly, finish with SADMA, past medical history and family history of heart conditions. So for SADMA, do you smoke, drink alcohol, recreational drugs? Past medical history, family history. Okay, so that will be your history of chest pain. You might wonder that it's a long history. It is a long history. What happens in exam, many times they give you a case of doing history for 6 minutes and then give diagnosis and DD for 2 minutes. So for those 6-minute case, the history needs to be a little bit more prolonged and extensive like this. But in case you have 3 or 4 tasks, then you have to cut it short. You don't need to ask all these differential diagnoses in this case. Okay? But that's how we will do a chest pain cluster. So making sure you start with the introduction, painkiller, vitals, taking the patient to the resuscitation room, doing all those things, then asking the chest pain question, then move on to all the DDs. So start with the MI, then aortic stenosis, pericarditis, then respiratory causes, GIT causes, musculoskeletal causes, neurological causes, and then psychiatric causes. Okay? Clear, everyone? Any question? And in the physical examination, it is also the same, like as we have discussed. Nothing is different. Only thing that you should add is during auscultation, along with murmur, you should also ask for any pericardial rub. And where do we get a pericardial rub? In pericarditis patient. All right? All right. So moving on to our task related to chest pain. So the mainly 2 cases come in the exam. One is pericarditis and another is acute myocardial infarction. So a 50-year-old tram driver presents with a sudden onset chest pain since 2 hours. Now looking at this question, can you think that it is a pericarditis case at first? Guys, if you read this case, will you think that this is a pericarditis case? No, you will not, right? So you will never think it as pericarditis unless you really get it in the exam. You will obviously think it as an acute coronary syndrome or MI. So your history and everything will be like that. And at the end, if you get pericarditis, that's fine. So first of all, positive points in the history was chest pain for 2 hours. And he has given a very typical history of pericarditis. So stabbing pain, aggravated by lying down and deep breathing, relieved by leaning forward. Sometimes the pain radiates to the back, had a flu-like illness a week before. So everything goes with pericarditis. So asking the history will help you a lot to differentiate between pericarditis and myocardial infarction. So in this case, your history will be same, like you will be doing everything that we have done as if it is a myocardial infarction, and you will be treating the patient exactly in the same way. So that means you will introduce with the patient, you will offer painkiller, and then take the patient to the resuscitation cubicle, and then you will hook the patient to the ECG monitor, arrange an ECG to be done, okay, making sure you will check all the vitals as well over there, and then take the bloods for necessary investigation, including cardiac enzyme. Okay, so up to this you will be doing. You don't need to straight away start aspirin in this patient. Once you have done the initial part, then you will move on to your questionnaires, just like we have done. And if you get this finding, then in your mind, you will think that, well, it can be pericarditis. After that, your next task will be physical examination will be given on the card. And then also they can say that and ask investigation from examiner, and then the investigation will be given on your screen. Or they can say ECG is given on the screen. So if ECG is given like this, what will you first check for? The main thing is that you know this patient has got a chest pain, and then obviously you will be looking for ruling out myocardial infarction in this case. So when you look for chest pain related causes, start with V1 to V6. So V1 to V6, these are chest leads, and these leads, lead 1, lead 2, 3, AVR, AVL, AVF, these are limb leads. Now, first of all, have an understanding that what exactly we look for. So this is the P wave. Then you have got this QRS complex, and that's the ST. Sorry, not like this. So this one. So what happens in here, this is the normal ECG, how it looks like. In a normal ECG, you can see that this is called isoelectrical line. And you can see everyone is on this line. Even your ST wave is on this isoelectric line, right? Now, in case of ST elevated MI, you will get this ST wave will go up. So it will go up from this isoelectric line, and that is why we call it ST elevated MI. Okay. Same in here, you can see that this patient's isoelectric line is this. And you can see the ST wave is here. So that's also ST elevation, right? This is understandable for everyone that how we get the ST elevation? Yes, very good. So if you understand ST elevation, then let's have a look on this ECG. So first of all, we will start with V1. V1, everything looks fine. A little bit of T inversion just starting. Now, if we see V2, P wave is fine. Then we can see that this is the isoelectric line, and there is already a starting of a ST elevation. V3 is quite prominent, so ST elevation. V4 ST elevation, V5 ST elevation, V6 ST elevation. Once we look at V1 to V6, these are called anterior leads. Then we look at the high lateral leads, which are lead 1 and AVL. Lead 1 and AVL. So have a look. So there is also ST elevation in lead 1, and lead AVL also having a little bit of ST elevation. Now, after that, we will check the inferior leads. In the inferior leads are lead 2, 3, and AVF. Even we can see in lead 2, there is ST elevation. Lead 3, not much. Lead AVF also having a ST elevation. Now, what you see here is called global ST elevation in almost every leads. And when you get a global ST elevation in almost every leads, that is not acute myocardial infarction. That is most of the time acute pericarditis. Okay? And acute pericarditis, the ST elevation has a characteristic pattern. It's called concavity upwards. You can see that it looks like you can sit on this ST elevation, right? So it looks like a chair. So this concavity upwards ST elevation, and it is everywhere, that's pericarditis. There is other thing you can also remember. Sometimes you might not get this much prominent ST elevation like this. In that case, always remember, if a patient has got an anterior MI, so if patient having ST elevation in V1, V2, V3, V4, in anterior MI patient, you should get a reciprocal ST depression in inferior leads. If ST elevation on V2, V3, V4 or anterior leads, ideally we should get either a normal lead 2-3 AVF, or highest we can also get a ST depression in lead 2-3 AVF. So this is called reciprocal ST depression in anterior myocardial infarction. That's the best way to differentiate between acute pericarditis and acute myocardial infarction. Did you guys get me? So all I said is that if there is anterior MI or in anterior leads there is ST elevation, then if you look at lead 2-3 AVF, they should have reciprocal ST depression, not elevation. Everyone clear about this reciprocal ST depression? Because that's the most important thing that will help you to differentiate in the exam. Because pericarditis, myocardial infarction sometimes can be quite tricky to differentiate. So if I repeat it again, you will find out that in these patients you have got ST elevation in anterior leads, high lateral leads, so lead 1 and AVL, and also in inferior leads, which never happens in myocardial infarction. In myocardial infarction, if you get ST elevation in chest leads like V2, V3, V4, V5, V6, then lead 2-3 AVF, you should get ST depression, or maybe just ST is normal. So either normal or depression, but never elevation like this. So that's reciprocal ST depression that we get in anterior MI. Okay, same in case of inferior MI, you will get ST elevation in lead 2-3 AVF, and ideally we should get ST depression in anterior lead. Okay, so that's called reciprocal. Anterior and inferior, there has to be opposite changes. So if it is anterior MI, then in the inferior lead you get ST depression. Okay, clear everyone? All right, moving on. So now that you know this patient has got acute pericarditis, so you'll explain that from history, physical examination, and the ECG, most likely you are having a condition called acute pericarditis. It is a condition where there is inflammation of the outer layer of your heart called pericardium. Most likely it is due to the reaction of the recent viral infection that you had. As the covering of the heart is inflamed, it's causing this stabbing type of pain that you're having, and that usually gets worse when you lie down and gets better when you lean forward. It could be due to other reason as well, so then give all other differential diagnoses, but make sure to say that please don't worry, it is most likely not a heart attack, but to confirm my diagnosis and to exclude heart attack, I would like to keep you under observation in the hospital. I will also call my senior, and also a cardiologist will come and have a look on you. In between that, we will do further investigation, including full blood count, inflammatory marker, checking your kidney and liver function. We will do repeated ECG to make sure there is no other changes. And we will do a troponin, which is a cardiac enzyme, can be elevated in heart attack. And also, if specialists wants, they can do an echocardiogram, which is an ultrasound of your heart, to make sure there is nothing else going on. And in case if it is confirmed as pericarditis, all you need to do is to take bed rest, and we will give you some painkillers for your pain relief. And most of the time, within few days time, you will be fine. Okay? So that's the management for acute pericarditis. All good. Moving on to acute myocardial infarction, super important for exam. A 55-year-old man comes to your emergency department with sudden onset crushing chest pain. Your task is to take history, physical examination, ask investigation from examiner, and explain it to the examiner, explain the likely cause of this chest pain and immediate management. Very, very important question. Now, this kind of case, most of the time I have seen that they give a ECG on the stem. And you already know that this is a heart attack patient, or it's an acute myocardial infarction patient. Okay? And then there are some other cases where you get the ECG later on after taking the history. So it depends on the stem. If on the stem you already get a ECG and you know that it is a ST elevated MI, the history you will make it short, because you don't need to ask all other differential diagnosis question in that case, because you'll be giving more time with explanation of the ECG and talking about the management in that case. But when there is a task with full history and then an investigation and then getting an ECG and then finding out the diagnosis, then nothing to do, you have to take a full history. So in this case, the positive point is acute onset of severe left-sided chest pain, crushing in nature, radiating to jaw, neck, and left arm, which is classic pattern, and for the first time. Associated shortness of breath, nausea, and vomiting. Smoking history positive, no other heart disease. So in this case, obviously what we will need to do is the same pattern that we have said. So first you introduce with the patient, and then you reassure the patient that you are going to take care of him. And then you offer some painkiller. And then you say that given that you are having a severe chest pain, I would like to take you to the resuscitation cubicle. And then I will then attach you, or you can say, so because you will be talking to the patient in here, you will say, I'm going to take you to the resuscitation cubicle. I will call my nurse, and then we are going to hook you on a cardiac monitor. We will make sure all the vitals are stable, such as blood pressure, your oxygen, pulse, and everything. And we will organize a ECG straight away. Then we will secure an IV line and take some necessary blood, including a cardiac enzymes, to make sure you are not getting a heart attack. And then based on your vitals, we will manage you accordingly. It's not like everywhere we will start the patient with oxygen. Only time oxygen will be needed if saturation is less than 95. Okay, so that's the case where you don't know the ECG yet. So up to this, you will be talking like this. But if ECG is already given on the stem, in that case, during this time, you can say that I'm going to take you to the resuscitation cubicle, and I'll attach you on the cardiac monitor to keep an eye on you, making sure all the vitals are stable, and then secure IV line, take the blood for necessary investigations, and also I'm going to start you with a loading dose of aspirin, 300 milligram. Okay, so you can start the aspirin in that case where you already know the patient has got an acute myocardial infarction. Okay. Now, some of you can ask that is starting aspirin initially, even before taking the history, is important and must to do? No, it's not must to do, but if you do it, it's also fine. And if you're going to do all the management at the end after taking the history, that's also fine. They're not going to fail you for that. Okay? The problem becomes that when you give the aspirin at first, if the patient asks you that why you are giving me aspirin, that's the time you become very confused, because then you have to say you have got a heart attack and you haven't taken any history yet from the patient. So that becomes a little bit tricky for the candidate at that time. So I would say that if you don't want to get that confrontation from the patient, better just to keep it up to this and then take the history. Then you're going to manage the patient with everything. Okay, so that becomes easier for you in the exam. But ideally in this situation, we would start aspirin straight away. Okay, so that's your first thing that you do. And obviously your history will be focusing on the chest pain questions, associated questions. You will be asking it a little bit more about, so you can ask few of the differential diagnosis questions, just a little bit. And then you will be focusing on SADMA mainly. So smoking history, family history of heart condition. You will be asking a little bit about, do you exercise and any stress in your life, any family history of heart condition, okay? And ask about previous history of high blood pressure, high cholesterol. So cardiovascular risk questions, you will be asking a little bit more in here, okay? So not a lot of differential diagnosis, but it's more towards the cardiovascular risk questions. So I'm discussing two different scenarios, so it can be a little bit confusing for you to understand. But idea is that if history is the task and you don't have the ECG on the stem, then it's the same format. That means you will be first taking the patient to the resuscitation cubicle and then asking all the chest pain questions, asking all the DD questions just like we have done, and then you get the ECG from the patient and finish it accordingly. Where you get the ECG, then the history becomes a little bit different because you already know this is an acute myocardial infarction case, and you will be focusing on MI related questions more. And they also say in that task that take brief history from the patient. So you will not be taking a huge amount of history in that case. And that brief history should focus on chest pain questions, associated questions, and then mainly SADMA, past medical history, family history, those questions. Okay. Now you have got the ECG. Once you get the ECG, then you will be first looking for making sure that it is the acute myocardial infarction. So if you look over here, what you see? So first V1, you can see V1 is normal. In the V2, you can see that there is a ST elevation. V3, that's more prominent. V4 ST elevation, V5, V6 ST elevation. So almost all the anterior leads having ST elevation. Then you look at the high lateral, so lead 1 and AVL. You can see that lead 1 also having ST elevation, lead AVL having ST elevation, and then you look at inferior lead. Now you can see this inferior lead 2 is normal, lead 3, there is a little bit of ST depression, which is the reciprocal ST depression, and lead AVF is also quite normal, just a bit of T inversion. Okay, so not even T inversion, this is the T. So lead 2, 3 AVF, you can say it's normal or showing reciprocal changes. So then you can confirm that this is an acute anterolateral myocardial infarction. Okay, so that's the acute myocardial infarction ECG. Let's see that if you can read this one. So it's the same one. If you look here, that start with the V1. V1 is little bit ST elevation, V2 ST elevation, V3, V4, V5, V6 is not much. Then you look at lead 1, there is ST elevation, lead AVL ST elevation. So already we are thinking about anterolateral. Lead 2, nothing much. Lead 3, fine. Lead AVF, fine. So that's again goes with anterolateral myocardial infarction. Okay, so let's talk about management of acute MI. So first of all, you will be saying that, thank you so much, John, for your waiting. Based on the nature of your chest pain and according to the ECG that we have done, I'm very sorry to tell you that I'm suspecting that you are having an acute myocardial infarction or heart attack. I'm really sorry, John, but it is a serious condition. In this condition, the blood pipe that supplies your heart gets blocked by clot and fatty depositions, and as a result of that, your heart muscle doesn't get enough blood and oxygen, and that can lead to serious complication, and sometimes even it can be life-threatening. But please don't get scared, John. You are in safe hand. And it's very good that you have come early and with proper intervention, it can be managed very effectively without any serious complication. I'm going to admit you to the hospital straight away, and I'm going to call my senior and the cardiologist who will do your further management. In the meantime, I have already taken you to the resuscitation cubicle, and you are already connected to the ECG to make sure your vitals are stable. And I have already sent some blood for necessary investigations. Now, while we are waiting for the bloods, I'm going to give you a tablet called aspirin, which you need to chew only. And this will help to prevent further clot formation. I have already given you a strong painkiller, and if you continue to feel the pain, we will give you some more painkiller or also add a nitroglycerin, which can sometimes help with the pain. If your oxygen comes down below 94, we will also start you with oxygen. Are you with me so far, John? Are you understanding me? Yes, doctor. The specialist might want to do further investigation, especially checking your full blood count, baseline blood test, so liver, kidney functions, your blood sugar and lipid profile, and also your cardiac enzymes. The definitive treatment of this condition is to remove the clot and restore the blood flow, and that is what we call as percutaneous coronary intervention or thrombolysis. This will be decided by the specialist based on the duration and severity of your condition. So most of the time, what happens is that once you enter into the hospital, and once we confirm that you have got an acute myocardial infarction or heart attack, cardiologist will take you straight away into the catheter lab for further management. Because this is a tertiary hospital, we have necessary step available in here, and most of the time you will be going for a percutaneous coronary intervention. In this case, the cardiologist will take help from the necessary specialist, and they're going to insert. You don't need to even discuss how the PCI works. All you need to do that they're going to do intervention to remove the clot from your heart arteries, and the specific management will be discussed by your specialist in detail with you. That's it. You don't need to discuss how the PCI works. You don't need to discuss about thrombolytic management. Nothing usually we need to discuss. The question asked to discuss about immediate management. The immediate management is monotherapy, which is basically what you have done so far: aspirin, oxygen, nitroglycerin, morphine, and you also talked about taking the patient to the catheter lab for PCI. If you can talk up to this, you are fine. Okay? And then you can say that, I understand that this is a lot to take for you at the moment, John, but you are in a safe hand, and we have a very good team of cardiologists in this hospital. Once you are stable, then you'll be sent back to home, and the specialist might put you on certain cardioprotective medications, which will be discussed in detail with you later on. We will also send you back to your GP to make sure you have you know about healthy lifestyle, to make sure that you can prevent further episodes like this in the future. Okay? And lastly, say that if you have any questions, John, feel free to ask me. And also, if you want me to call your partner, friends, or any family members, please let me know. We are more than happy to contact them. Okay? So you don't need to talk about the red flags at the moment. You don't need to talk about healthy lifestyle, what we are going to do after the patient is discharged. This is not the immediate management at this moment. Okay? So at this moment, the main thing that we are going to discuss is first talk about what is heart attack, then talk about giving all the monotherapy, and then PCI. That's it. There is a case where that was the case of ECG given on the stem, and the patient is in a rural hospital, and then there is no PCI available. They already give you in the stem that patient is in a rural hospital, and the nearest hospital where PCI is available is 2 hours away. We say that we can't wait for 2 hours for the transfer. Once a patient comes into our door with an acute ST elevated MI, you have to do a PCI within 90 minutes. If more than 90 minutes, you don't need to wait for PCI. You can go for thrombolytics. And in a rural hospital, that most of the time, that is the only thing that's available. Okay, but this is the but we can do PCI if patient comes within 12 hours of onset of symptoms. So PCI can be done if patient comes within 12 hours, but the main thing is that in a rural setting, if you don't have PCI available and your nearest tertiary hospital where PCI is available is more than 90 minutes away, you would not send the patient. Rather, you would consult with the cardiologist over phone and then start the patient with thrombolytics. And once patient is a bit stable, then you can transfer the patient back to the tertiary hospital. Okay? In that case, you have to talk about a little bit about the thrombolytics. So we will have a discussion about this in our role play session, that how that case will work, and we will be doing a role play so that you understand about that case. Okay, but I'm giving you a bit idea that if it is a tertiary hospital more than 90 minutes away, ideally we don't need to send the patient to them. We can start with thrombolytics. And PCI is basically, it's just stenting. So you insert a flexible wire into the coronary artery, find out where is the clot, and then you remove the clot and put a stent there to dilate the coronary artery. That's PCI. Now, if PCI is not available, then you do the thrombolytics, which is a medication to dissolve the clot. But there are some contraindications for starting thrombolytics, such as if a patient has active bleeding disorder, if a patient is actively bleeding at the moment, had a hemorrhagic stroke in the past, or ischemic stroke within the last 3 months, or there is a feature of aortic dissection, you can't do thrombolytics. Okay, so those contraindications you have to rule out in your history. All good, everyone? Any questions? And Dr. Marco, if this ECG, which is like we are discussing now about the ST elevated MI, if you need to explain that ECG to the examiner, do we need to follow the order? Yes, you should follow the order. So talk about all the P wave and everything, and then say there is ST elevation in these leads. Yes, that's also a good thing, Dr. Victor. If a patient confront you after giving the aspirin initially, that why you are giving me this medication, what I have got, you can say that, yes, I'm suspecting a heart attack, so I'm making sure that if that is the case, you are well protected. You can say something like this, but if you don't want to get caught into this conversation, you can just say the aspirin later on in the punishment. Saying that thrombolytics is also if a patient presents within 12 hours of onset of symptom, that is the best time for thrombolytics and PCI both. Do I need to tell about axis deviation in ECG explanation? No, they don't care about axis deviation. Okay, now we will try to finish this case, angina, but it's not super important for your exam. And this might be our last case for tonight. Let's see how much we can do. So you are in a GP setting, a 62-year-old male who presented a few days ago with chest discomfort. ECG done at that time was normal. A stress test was done later on, showed ST segment change in anterolateral leads. Patient had chest tightness during the test. Patient is a smoker, no history of diabetes. Explain the test result, short and long-term management. So sometimes in exam, the cases comes like not super important, but it just comes in exam. So you have to have an idea about those cases. but it's not super important like the acute MI case. So you can understand from this stem that it's a 62-year-old who had a chest pain, but ECG normal. And a 62-year-old having a chest discomfort, even if resting ECG is normal, you are not just stopping there. You will try to find out that if this patient having any angina. So you will send the patient for a stress test. And in the stress test, if you find any changes, like if patient become symptomatic or in the ECG there was some changes, you can diagnose them with angina. So first of all, your task is no history here. Just explain the result and give short and long-term management. So it's all about talking, no history. So there are cases like that in the exam where you don't need to take any history, just explain it. Just again, introduce with the patient and then say that hi John, this is Dr. Arshan, one of the GP in this clinic. It's very nice to meet you. I understand from the notes that you are here to get the results of the stress test that we have done. Is that so? Yes, doctor. So how are you feeling today? Are you getting any chest pain? No, doctor. Well, I have got your test result with me. I'm going to discuss it in detail. If you don't understand me at any point, feel free to ask me again. So from the stress test, that what we have got, John, is that most likely you are having a condition called angina. Do you know what it is? No, doctor. Well, angina is the name given to the chest pain or discomfort that comes from the heart when it is short of oxygen. The heart is supplied by blood pipes known as coronary arteries, and in this condition, these blood pipes get narrowed due to deposition of some fatty substance. As a result of that, when you do some exercise, your heart can't get enough oxygen, and that's why you get the chest discomfort. Are you with me so far? Are you understanding why you are getting chest pain when you are doing some exertional work? Yes, doctor. But please don't get scared. It is not an uncommon condition. Millions are suffering from this. But unfortunately, it can lead to serious complications such as heart attack. That's why it is important to follow a healthy lifestyle to prevent any further deterioration of this condition. Regarding the management, I'm going to start you on some medication such as aspirin, which will prevent clot formation, beta blocker, which helps with prevention of cardiac muscle remodeling, statin, which will lower down your cholesterol and these fatty depositions, and a nitroglycerin spray, which will help to dilate your blood pipe of the heart. And whenever you get the chest pain, you can take it and you can see that your chest pain is getting better with that. Also, try to have a healthy lifestyle. So if you are drinking alcohol, try to cut it down to the safe level. Avoid smoking. Try to maintain an ideal body weight. Healthy balanced diet. Do some exercise, ideally 30 minutes brisk walking on most of the days of the week, and try to avoid stressful works. For further management, I'm going to refer you to a cardiologist for further assessment and management. Also, now in this case, you can also do some blood test as well if you haven't done yet. So all those necessary blood tests you will be doing is you'll be organizing full blood count, liver, kidney functions, thyroid functions, but most importantly, blood sugar level and lipid profile. And cardiologists most likely will be going for a specific investigation called angiogram. And you can also discuss what is angiogram. So in angiogram, a flexible wire will be inserted into your coronary artery, and they will find out the level of your coronary artery blockage and how much blockage it is. And based on the angiogram result, the next step will be decided. If it is not severely blocked, or if not multiple arteries are blocked, they can just put a stent in the arteries to keep it open. Or if you have multiple severely blocked coronary arteries, they can even want to go for an open heart surgery. This will be discussed in detail by your specialist later on. Now, John, if you again have this kind of chest pain, please follow the angina action plan. So you have to discuss this angina action plan. So if you have this chest pain, even after taking rest, it is still there, take this nitroglycerin spray under the tongue. Wait for 5 minutes. If the pain doesn't relieve, then notify a friend or having the chest pain. And repeat the dose after 5 minutes. Wait for another 5 minutes. If it's still not relieved, call ambulance, take the third dose, and tell the ambulance that you are having a heart attack. So we say that it's called 3 times patient can take the nitroglycerin spray. First, they take it, wait for 5 minutes. If still there is chest pain, they take the second dose. Okay? And wait for 5 minutes. Even after 5 minutes, still chest pain, call the ambulance, take the third dose. Okay? So that's angina action plan. And lastly, say that I'm going to give you some reading materials about everything I have discussed, and I will review you once the blood tests are back. And also, you can say that, like, obviously, you're going to review the patients regularly, and also give some red flag that if any time you get a persistent chest pain and the chest pain doesn't get better with nitroglycerin, as I have discussed, please go to the emergency department or call the ambulance immediately. Okay, so that will be your angina explanation. It's important to know at least, so that in case it comes in exam, you will know how to discuss. Okay, so that's all about this thing. Now, we don't discuss angina due to anemia this case. You can read it from the portal. The only thing that we discuss is CVS risk assessment. CVS risk assessment is something like this. See this one? So this is called CVS risk assessment chart. Now, I haven't seen this to come for a while in the exam, but it is something which you should know. Okay, so there are 2 different cases for this, which we will discuss in our cardiology question solve or cardiology role play class. So before we start doing the role play, we will discuss this CVS risk assessment one. It takes a little bit of time, so we will be discussing that first, and then we will be doing some role play. Okay, so that's how we would proceed. Any questions on today's class? And you know that you have another random question discussion tomorrow. Yes, Dr. Jahra, you can ask. That's fine.
Hello, Dr. Chan.
Yeah.
I just wanted to ask, in online examination, there will be vital mention or not?
It depends. Sometimes there is vitals mentioned, sometimes not.
So
So
if
most of the time we see that they give in this time that the vitals are stable, or they give all the blood pressure, pulse, everything they give. Sometimes they don't give at all.
okay, if they did not give any, like if they do not give any vitals, then we just have to say like that I'm going to check
Yeah.
your vitals. And then how do we know that we need to shift this patient in resuscitation cubicle?
The only time we do it is this case in online exam, or if in the STEM you see that patient is vitally unstable. Okay, because you are not getting it from the examiner, so you don't know what is the vitals unless it
Yeah.
is given to you. But for a case like this one, this is very, you already know from this term that you are looking for what. So in any middle-aged or elderly patient coming with chest pain, which is acute, that patient will go into the resuscitation cubicle in the emergency department. Okay, so
Okay.
it's straight. So that's what we are doing in here also. Even though we don't know it, we are taking it because we are cautious and we are worried about that patient. And
Okay.
in other cases, yeah.
Yep. Continue.
Yeah, in other cases, like let's say they have given you in one case, like incomplete abortion case, they have given in the STEM, patient's blood pressure is 90/50. In that case, yes, again, initially, when you start talking to the patient, you have to take the patient to the resuscitation cubicle do all the necessary steps, even start the patient with IV fluid in that case. So if you know from the stem patient is unstable, then you also take the patient to the resuscitation cubicle initially.
Okay. Thank you, sir.
No worries, Dr. Jahara. Any other questions, guys? Now, you know that tomorrow is also Dr. Cynthia's class, which will be mainly on random question discussion. And it will be starting from the same time today, because there was a little bit confusion last time. So we will on the same time, which is 8:30 p.m. Sydney time. So join the session tomorrow as you are doing also. And I'm hoping that you are liking the class. There is only 1 week left for these 3 sessions to be finished. And we have already organized our orientation class to start on 25th. So your free 2-week session will finish on 22nd, which is next Sunday. And after that, 25th will be the orientation class. So if any of you are here who haven't joined the session yet, I would suggest that please start the process, because we also would love you to get a smooth start of the journey. So if you don't do it right now, sometimes it takes a little bit of time for you to get all the access. Our team is doing very hard work right now, but still it takes some time, because everyone we are giving access, we are talking to them, so lots of things. So I would advise for a smooth start the process now. If you like the classes, this is how we take class. There is no hide and seek in here, and I'm hoping that this is all that you would need for your exam preparation. And also, as we have said, that if any of you are here who is preparing for exam on November or maybe early next year, such as February, March, we already started putting all the previous batch recordings in your portal. So you can always go through those portal, finish everything that you need for your exam preparation in your own pace. And you can join the live sessions as well. Okay. So anything that you want, you can always ask us in the messenger or in the email. We always try to help you in every possible way. Okay. All good then. So let's finish it here tonight. Thank you, everyone. Take care. Have a good night. Bye.